All right, guys, we're going to go ahead and get started with chapter 33, which is our postpartum complications. You can read through the learning objectives there. So, postpartum hemorrhage, it is an obstetrical emergency that can occur with little to no warning. The definitions listed here is a cumulative blood loss of 1,000 milliliters or more, and it's associated with signs and symptoms of hypovolemia within 24 hours of the birthing process, regardless of the type of birth. So you can have a postpartum hemorrhage with both a vaginal and a C-section delivery. It is the leading cause of maternal morbidity and mortality, and it's often unrecognized until the mother has profound symptoms. This is why it's so important that we're doing those fundal checks and we're checking for bleeding, just because we don't want to wait until the mom is having more profound symptoms, because then it's harder to control at that point. Postpartum hemorrhage is classified as early or late. I would definitely know the difference of the two. And so early acute or primary postpartum hemorrhage, that's going to occur within that first 24 hours of delivery. And then late or secondary postpartum hemorrhage is what's going to occur either that following that first 24 hours after delivery, but less than 6 weeks after birth. So this means that a mom can even be discharged home from the hospital, be 2 to 3 weeks postpartum, and still have a postpartum hemorrhage. All right, so we're going to talk through some of the causes of postpartum hemorrhage, kind of talking through the etiology and some of the risk factors. So what happens immediately after delivery and that placenta is delivered? We want that uterus to clamp down, kind of contract on its own to prevent excessive blood loss. So in reading through this, that uterine atony, which also a term that we sometimes use in the clinical setting, is bogginess. So if you've ever heard them say their uterus is boggy, they're kind of interchangeable. So uterine atony is a marked hypotonia of the uterus. It's when there are inadequate uterine contractions and the uterus remains flaccid, and rapid blood loss can occur. This is the leading cause of postpartum hemorrhage, especially very early on post-delivery. So definitely make sure that you understand that. Read through those chapters if you have a few more questions. It is associated with high parity. So if you're in your moms who've been pregnant with their third, fourth, fifth baby, just think that muscle over time, it has expanded multiple times now, so it may have a more difficult time kind of clamping back down back to its normal size. Hydramnios, so especially with polyhydramnios, so when they have excessive fluid, that uterus has already been overexpanded, so it may have, again, a more difficult time clamping back down. Macrosomic fetus, so those babies who are 8, 9, 10 pounds. Obesity is also a factor, and multifetal gestation. So, moms who have twins, triplets, again, that uterus has just been overextended, and it may take a little bit longer for it to start clamping back down. And so if this happens with uterine atony, we definitely want to control this and control it very quickly, just because of the rapid blood loss that can occur. So what we're going to do is the fundal massage. So you may have seen your provider do this post-delivery, and then your nurses are usually doing fundal massages very frequently as well. Usually about every 15 minutes or so, and that's that first couple of hours after delivery, and then usually once or twice per shift thereafter. We want to make sure that fundus is staying nice and firm and that mom's not having excessive bleeding. And so if you were to see a test question about this, what I would want you to know is, first of all, what is uterine atony or a boggy fundus, and then what do we do for it? So with this specifically, we're going to do least invasive to most invasive. A lot of times the fundus will react, and we can just do a little bit of fundal massage and it'll start to firm back up and do great. Other times, we may have to, maybe if the mom needs to pee and her bladder is extended and it's putting pressure against that uterus and it really can't clamp back down because the bladder's in the way, we may even have to straight cath her. Surgical intervention, so if there's like retained placenta or placenta fragments, sometimes that can be a reason why that uterus doesn't want to clamp back down. But we always want to start with the least invasive, going to the most invasive. So massaging that fundus is definitely going to be one of our first interventions there. Also with breastfeeding, so breastfeeding is kind of a natural way to help this happen. So as a mom breastfeeds, a lot of times that uterus will contract on its own as well. And so you may see that some too in the clinical setting as moms are breastfeeding or saying, oh, I'm having contractions when I'm breastfeeding. That's just, again, kind of nature's way of kind of helping that process along just a little bit. So all good things, but definitely just know what uterine atony is and how we would respond to it. All right, so some placental complications that can occur may be that retained placenta. So as we've discussed before, we like to see that placenta delivered in about 15 minutes post-delivery. So if after 15 minutes that placenta has not detached on its own, then we have to start being concerned that there may be something else going on. There's a reason why it's not detaching at that point. And so that may require that we take the patient back to the OR for the doctor to manually remove it. Additional complications that can occur would be fragments of the placenta that remain. So if you have a placenta that's kind of coming out in pieces, or it's not intact, that may require a manual sweep from our provider as well. We just want to make sure all that's out so that placenta can definitely clamp down post-delivery. Unusual placental adherence, so that can be your placenta accreta, increta, or percreta. I don't want you spending a ton of time focusing on these. I just want you to be familiar with those terms in case you were to see them later on with ATI or NCLEX. But I'm not going to ask you specifics on which of those is which on the exam. Lacerations of the genital tract. So this may be seen where you're having like some bright red bleeding, and it's a steady trickle, especially immediately after delivery. And so our first thought is going to go to, oh, could this possibly be a postpartum hemorrhage? And so we definitely want to try to differentiate between the two. And so the way that we can do that is by doing our fundal massage. So if we're doing a fundal massage and that fundus is nice and firm and it's clamping down, then we can say, okay, it's probably not a postpartum hemorrhage at this point. I think it's just a laceration of the genital tract. And so that is going to be the differentiator there, is that fundus is going to be nice and firm. So definitely know that if you have a question related to that, how are you going to differentiate between the two? And then with your hematomas, your patients are usually just going to have some pain in that general area. So inversion of the uterus, this is an obstetrical emergency that's really rare, but is potentially life-threatening, occurring in 1 out of every 2,000 to 25,000 births. It is an emergency because it can lead to hypovolemic shock. Subinvolution of the uterus, it's the cause of late postpartum bleeding. And so again, these are your moms that have already usually gone home or been discharged. That's why it's so important that we're doing that postpartum teaching. Signs and symptoms include prolonged lochia, discharge, irregular or excessive bleeding, and sometimes hemorrhage. And so this is due to a delayed return to a non-pregnancy size of the uterus post-delivery, and it is the most common cause of late postpartum hemorrhage. So here's just a figure on interprofessional care management of a postpartum hemorrhage. It is figure 33.1 in your book, and you can kind of just read over that so you're familiar with it. All right, so postpartum hemorrhage interprofessional care management. So we must develop a standardized management protocol and regularly conduct emergency drills. So most of your OB units are going to do these at least yearly, if not bi-yearly, just to ensure that every one of the staff members are well aware of how to handle a postpartum hemorrhage. And so with this, it's going to come the assessment. So that's the early recognition and treatment of postpartum hemorrhage. So again, that's why we're doing those fundal checks very often, especially those first few hours post-delivery, about every 15 minutes or so. Medical management is going to be the firm massage of the uterine fundus, elimination of the bladder distension. So if that bladder is full, it often shifts over that uterus a little bit, which prevents it from clamping down. So we want to make sure that bladder is remaining empty as well. And then we're also going to continue with the IV infusion of anywhere from 10 to 40 units of oxytocin post-delivery. And so again, that just varies per provider. Surgical management after delivery. So if we've done everything else and we're still having issues with postpartum hemorrhage, one of the options at that point, again, least invasive to most invasive, may be a uterine tamponade, which is a Vauchery. Again, we're not going to go into too many specifics on that because we're preparing you to be generalist nurses. But with the Vauchery, it's kind of like, I guess we can equate it to like a uterine catheter. And so it actually goes up in to put pressure inside the uterus to prevent the excessive bleeding. And so then, of course, your nursing interventions with this, we kind of already discussed, but if you get a test question related to this, how are you going to assess the postpartum hemorrhage? Least invasive to most invasive. You're going to do that fundal massage. You may need to start IV fluids if we haven't got IV access. So this is a mom that maybe just rolled off the elevator and delivered. If we haven't achieved IV access at that point, we definitely want to have IV access for these patients. Cath the patient. So if we've tried everything else and maybe her bladder is starting to fill up, and that's part of the problem, we may have to catheter at that point. And so just know what those interventions need to be and how to act accordingly. Hemorrhagic or hypovolemic shock. Definitely read over those chapters in your book. You need to know what that is and how we would confirm that diagnosis. Specifically, what are the symptoms that you would be seeing in your patient? So those could be pale and clammy skin, lethargy, a decreased urinary output. Just know what all the signs and symptoms of the hypovolemic shock are. So hypovolemic shock can be the result from a hemorrhage. It is an emergent situation in which perfusion of the organs have become severely compromised and death may occur. And so looking at the interprofessional care management, this is why those standardized management protocols are so important. We want to make sure that all of our staff are well educated on how to respond accordingly. We do those drills yearly or bi-yearly. And again, proper staffing. This is where that is a key player here, because if you only have one nurse at the bedside, you want to be able to call additional staff in to be able to help in that emergent situation. And so we want to restore the circulating blood volume in eliminating the cause of the hemorrhage. So we want to know why. Why are they hemorrhaging at this point? Is it retained placental fragments that haven't been removed? Is it a full bladder? And so we need to maybe potentially cath that patient. And so getting to the root volume of it, sometimes that can be your quickest fix to these. And so while we're doing all these other things as well, we want to try to get to the appropriate cause and try to eliminate that. Fluid or blood replacement therapy, again, that's why it's so important we have IV access with these patients. So you have to think of your patient that just came off the elevator and had a baby within 30 seconds of walking through the door. Odds are she doesn't have an IV. And so we need to make sure that we're starting an IV to either do a potential emergent blood transfusion or to give her fluids or Pitocin, whatever we may need to do at that point. And then restore oxygen delivery to the tissues to maintain cardiac output. So our coagulopathies, when bleeding is continuous and there is no identifiable source, a coagulopathy can be the cause. The woman's coagulation status must be assessed quickly and continuously. So that's why, again, it's so important that we're getting baseline labs on some of these patients. We're getting their medical history, because these can all be factors post-delivery, potential bleeding complications. So your patients that have ITP or von Willebrand's or any type of hemophilia, we really need to know about that ahead of time so that we can respond appropriately if needed. So next we're going to talk about our venous thromboembolic disorders. So VTE, that is the result of the formation of a blood clot or clots inside of a blood vessel. So some of this may be a little bit of a review for you guys. So just kind of read through each of those. Just superficial venous thrombosis, our deep venous thrombosis, and our PEs. Again, I'm not going to go into great detail during lecture or on the exam, but just to be familiar, it should be a little bit of a review for you as well. But if you have any specific questions on those, please let me know. So incidence and etiology is going to occur 1 out of every 1,500 pregnancies. A major cause is going to be venous stasis and hypercoagulation. And then cesarean births nearly double the risk for VTE. Our clinical manifestations are going to be a superficial venous thrombosis, which is the most common form, generally characterized by pain and tenderness in the lower extremity. DVT and PE, you guys can read back over that previous slide about those if you have specific questions. And then just know that thrombophlebitis, if there's a question about that, well, you need to tell me how is that confirmed or diagnosed. Just no specifics on that. And then the interprofessional care management, what would the nursing staff do? So ongoing assessments, what type of education are you going to provide, and what could you potentially anticipate for anticoagulant use and the nursing care the patient's going to receive. All right, so postpartum infections, these are going to be any clinical infection of the genital tract that occurs within 28 days after miscarriage, induced abortion, or birth. So again, you guys who are not planning on going to obstetrics, these are patients that you could potentially see in the office with their PCP or in the emergency room perhaps as well. And so this is defined as a presence of a fever of 100.4 or greater on 2 or more consecutive days of the first 10 postpartum days, not including the first 24 hours after birth. The reason we don't necessarily include the first 24 hours after birth is because we usually will see a slight increase in their white blood count that first 24 hours. And so while this can be a normal finding, a lot of times we have to use our clinical judgment. So if we have a patient who has a white count of, say, 9, and then 24 hours later on their CBC, it is now elevated to an 11, then that could potentially be explained just from the delivery itself. However, if they've gone from a 9 to a white blood count of 20, then that could be more cause of concern, especially when it's in the presence of also these postpartum these infection-like symptoms. So having a fever, greater than 100.4 on, days 3 and 4, that's definitely warrants a call to the provider. And so that's education that we're going to want to make sure that the patients have prior to being discharged from the hospital. Endometritis is the infection of the lining of the uterus. It is the most common postpartum infection. We see this a lot in our moms who've had a prolonged labor or rupture of the membranes. And so we may also see it with our C-section deliveries as well. And so what providers do many times is they actually give prophylactic antibiotics, especially prior to the C-section, just to prevent any additional risk for an infection. Wound infections often develop after mothers are discharged home. And so the rates of a wound infection after a cesarean birth are about 3 to 5%. We also can see wound infections with those moms who've had an episiotomy or a tear. So when we're thinking back to those 1st to 4th degree tears, you can see why it's so important that we're providing proper education on how to care for those and what to watch for. So education is super important. We want to start providing education, from the moment they walk through the door to the moment that they're discharged. Just because we're overwhelming them with so much information in those first few days, we definitely want to make sure that they understand what's normal and what's not, and when they need to seek care from their provider. And so with an episiotomy, we want to discuss, cleanliness, signs and symptoms of what they need to watch for, and when they need to call their provider. Urinary tract infections occur in about every 2 to 4% of postpartum women. Just think of all the stuff that's kind of been happening down there. She's potentially had, multiple caths since she's been in labor, in delivery, post-delivery potentially. She's had multiple pelvic exams. So again, just know the signs and symptoms of what they need to be watching for. How are we supposed to be educating them and what they need to know prior to going home. And then interprofessional care management, assessment, and interventions. So again, we're just going to want to make sure that we're providing them with all the signs and symptoms when they need to seek care. And so you guys who potentially may not be going into obstetrics, who are working in the ER or working in a PCP provider's office, these are the patients that may come in to see you a week, 2 weeks post-delivery. So just know that these are all the risks that those moms may encounter. All right, so our key points. So postpartum hemorrhage is a major cause of obstetric morbidity and mortality throughout the world. It's the leading reason for obstetric intensive care unit admissions. Hemorrhagic or hypovolemic shock is an emergency situation. Potential side effects of therapeutic interventions can further compromise the woman with a hemorrhagic disorder. Clotting disorders are associated with many obstetric complications, and postpartum infection is a major cause of maternal morbidity and mortality throughout the world. And then postpartum UTIs are common because of trauma experienced during labor. Prevention is the most effective and least expensive treatment of postpartum infection. All right, so I wanted to go over this question. So a physician orders Methergin for a postpartum client. Which intervention should the nurse take prior to administering this medication? So I want to go over that because we really haven't talked about Methergin. I wanted you to at least be familiar with what that is, in case you happen to see it on an exam or ATI. So Methergin is one of the medications that a provider may choose to use for a mom that's having a postpartum hemorrhage. And so in this case with Methergin, it is a contraindication to use that with patients who have elevated blood pressure. So the answer to this would be A. But again, I just wanted to make sure that you guys were familiar with it, whether you heard it in the clinical setting and saw them used there, or if you happen to see it later on. I knew that was probably one that you weren't super familiar with or had a lot of experience with. So I just want to make sure that I covered that as well.